Okay, now we're going to talk about labor and delivery, the labor and birth process, one of my favorite parts of nursing and women's health. Our objectives are here. By the time we're done with our module, you'll be able to monitor the mother and fetus during labor and birth. That's going to include some fetal monitoring lessons. Identify the factors that affect the birth process. There are reasons that sometimes babies don't deliver vaginally, and you'll be able to recognize those. Identify the onset of true labor versus not true labor and intervene as indicated, or to know what the provider is going to most likely do to intervene. And recognize the different stages of labor and the client's responses to each. And that's important to understand as far as knowing how labor progresses. Let's start off with the 5 factors that affect the labor and birth process. We call these the 5 P's of labor. The passenger, which is the fetus, of course. The passageway, which is the mother's birth canal. The powers, those would be the contractions. Are they strong enough? Are they occurring frequently enough? So the powers of labor can be something that needs to be corrected in order to deliver vaginally. Position of the laboring woman, that can make a difference. Lying flat on your back is not going to promote labor. Getting up and walking, being on your side, those are the things that will promote labor. And then the psychological response. It's been shown that women who have high fear are unable to relax, and they will actually prevent dilating even though they're in pain. We're going to talk about some diagnostic procedures that are done. Some of them require machinery, others require just our hands and our experience. We'll start first with Leopold's maneuvers, and I encourage you to look in the book for pictures of this, because it's going to be easier to see than it is to describe. But Leopold's maneuvers help determine basically how the fetus is lying inside the mother, and whether or not to give us ideas whether or not she can deliver vaginally. If you can realize a baby laying sideways in the uterus is not going to be able to deliver vaginally. So Leopold's maneuvers is how we determine how that baby is positioned in there. It's abdominal palpation of the fetus, and the first thing we look for is that presenting part. What that means by the presenting part, that's the part that's presenting to the cervix to come out first. And ideally, of course, we want it to be the head. The vertex is what it's called. We want it to be the vertex presenting, because that is step number 1 to being able to deliver vaginally. The breech, if there's a breech presentation, that's where the butt or the feet would come first. The butt is a complete breech. The feet first would be called a footling breech. Breech babies can be delivered vaginally, but today's physicians do not have the training to do breech deliveries. They are always C-sectioned, except for my daughter. I'll tell you about that later. But I mean, her baby was breech, and I delivered her vaginally. But there were reasons I knew I could do it that way. Yes, I delivered my 3 grandkids. I was my daughter's midwife, so that was really cool. So anyway, we're going to palpate to find what's presenting, if it's the vertex. Then we need to know what's called the lie, and that is the way the baby is laying in there. Is the lie horizontal, which would not be deliverable vaginally? Is the lie vertical, which is what it is required to deliver vaginally? The baby must be up and down like the mom's spine. The attitude, and that's not the mother's attitude. The attitude is the word that is used for how is the baby's head facing and positioned. Ideally, well, the only way a baby can deliver vertex is if the chin is it flexed down towards the baby's chest. It's the flexed attitude of the head. If the baby's head is extended backwards so that you're having a face presenting, that baby cannot deliver vaginally. Put your own head back as you listen to this and imagine how wide that diameter got just by doing that. Now bend it, flex it forward, and you'll see that is the smallest diameter that fetus can get into. So that baby needs to be in a flexed attitude position. Okay? Descent is how low is the baby in the mom's pelvis by our palpation, and then we determine where is the probable location of the heartbeat. Just realize that the baby's heartbeat is going to be found near the baby's back. See, the heart, of course, is here. We're going to hear the heartbeat at the back towards the head. We won't hear it down here. It's going to be up here. So if we know that the baby is breech, we're going to get the heartbeat up by mom's belly button because that's where the head is. The head's up high and the butt's low. If the baby is vertex, we're going to get that heartbeat down by the mom's pubis area to the right or left lower quadrant of the abdomen, depending on how the baby's laying. So what you need to understand about that is, in order to find heart tones most easily, you need to find the baby's back and head, okay? If you had a question that asked for, we're hearing heart tones on the lower right, here's the mom's abdomen, all right, lower right, that would be a vertex baby because the head would be here. This is crazy to do this, and the back would be here, and legs or whatever. Okay, so we're going to have a vertex. If you were given a question about the heart tones up here by the belly button, then you know the baby's breech. Okay, so just look at your pictures on that. Another type of diagnostic procedure we do is fetal monitoring. That's where we hook the mom up to monitors. There's an ultrasound transducer which measures the heartbeat, and then there's what's called a tokometer, which measures contractions by tightening, and that's this. I'm kind of doing these both together. Okay, the fetal monitor is the external. There's external and internal. We're just going to talk about external now, and that's where we would play. Like, where would you put the fetal monitor on this to hear the baby's heartbeat? Yeah, you're going to put it right here, right over that lower left quadrant of the mom. See, her head's up here, so it's the left side. Looks right, but it's the left side. So you'll put the fetal monitoring right there. Now the ultrasound, the contraction one, the TOCO, we're going to put that up at the fundus of the uterus because that's where the uterus is going to be best able to pick up tightening and loosening, tightening and loosening. Okay, the baby's butt's probably up there, allowing a counter pressure area so that tightening uterus will have something to push against to measure contraction. So you got a contraction, here's a slow, and then it starts to go up. That's contraction getting stronger, and then it comes down and it relaxes. So that's what a contraction looks like. Vaginal exams are another way to determine progress in labor, and that's just done with our fingers, and with experience you're able to tell progress from not dilated, what's called long, thick, closed, to completely effaced and and dilated and ready to deliver. Labs are another important evaluative thing we need to do with women in labor. Women are going to lose blood when they're in labor. That's nature of labor, and we need to make sure that they can tolerate that. And the two major things, well, there are three major things we look for in the lab work. One is the CBC, the hemoglobin hematocrit. Okay, so basically there's a healthy hemoglobin level there. And we also look for platelets. Platelets indicate whether or not the mom's going to be able to adequately clot after delivery. If the platelets are low, these women are not going to be happy because women with platelets less than 100,000 cannot get an epidural because of the risk of bleeding from the epidural hole that the anesthesiologist has to make. So they are not happy when they have low platelets, but it's important to identify those at-risk people. The other one we look at is the white count. If that's normal, then we have evidence of no infection, and that's always good to know with someone in labor. So those are the basic diagnostic things that we do when on admission to see how to start the monitoring of this woman in labor. True and false labor, this is what I want you to understand about true and false labor. The definition of true labor is right here. Leads to cervical dilatation and effacement. Effacement is the thinning of the cervix. Ooh, this is hard to do. So anyway, if the cervix is not changing, they're not in labor. They're just not in labor. That's the definition of true labor, is cervical change. If I had one thing to pull out of this chart, it would be this one. That is required to be considered true labor. Some women, you may have friends or family members, oh, I was in labor for 4 days and oh, they wouldn't do anything to help me or whatever. Well, I hate it, and I would never say this to them because they're sure they were in labor for 4 days. But the bottom line is if their cervix was not changing, they were not in labor. Now, that does not mean they were not uncomfortable, but Braxton Hicks can get quite awful feeling, and Braxton Hicks are those false labor contractions. But one thing I would tell patients to do if they've been laying down and they think they're in labor, get up and walk around. If you're in real labor, the walking around may cause the intensity to increase. If you're not in real labor, walking around may cause them to go away. And conversely, if they've been walking around and they feel contractions, lay down. Laying down will not stop true labor, but it might stop false labor. And a warm bath will also help relax some of this pain that they're getting over here, because it's not that it's not uncomfortable, it's just not doing anything to reward them for their pain. So just understand, this is the bottom line definition of real labor, is cervical change. Nothing else, really. Lightning, these are some physiological changes that may happen before labor. Lightning is where the baby's head drops into the pelvis. And the patient, this does not always happen. Patients do not always feel this. But if they do, the baby feels like it literally has pumped from being in the woman's chest and lungs to being down on the bladder. The baby literally sits down in that pelvis better, and so the patient, the mom can actually breathe better because she has more lung room, but now she's peeing all the time because she's got a baby sitting on the bladder even harder. Lightning is not an imminent sign of labor. It means that probably in the next couple weeks you're going to go into labor. That baby's getting into the position it needs to, and it's getting ready. Backache, some women describe that as kind of menstrual cramp feeling, but that may be happening prior to labor starting. It's kind of, ooh, I don't know what's going on. I don't feel good today. Contractions, we talked about the Braxton Hicks, and they may eventually progress in strength and regularity and eventually start causing cervical change. Write this down. The definition of adequate, nope, we're going to talk about adequate labor and fetal monitoring. Never mind. Don't write that down yet. We'll do that on another lesson. Bloody show is a brownish or blood-tinged mucus discharge. The cervical mucus plug is another way it's called, another thing that it's called. Understand that when a woman is pregnant, she has the cervix will create a large amount of mucus that literally sticks to the cervix itself and covers the opening up into the uterine area. This provides protection from infection. This is why it is okay for pregnant women to have intercourse during their pregnancy, because the non-sterile male penis is not going to be able to introduce bacteria into the uterine environment because this mucus plug prevents it from going in there. As the cervix changes, dilates, thins out, which is effacement, is called thinning out, as it's changing in ways with labor starting or getting ready to start, the mucus plug loses its tight connection to the cervix and it will fall out. When I say fall out, it may wipe out, it might, don't be literal about it, but it'll come out, and it's because it's no longer clinging to the cervix. That's where you might have blood tinged, because it popped a few little blood vessels on that cervix. Understand that in pregnancy, the blood volume, if you remember, blood volume increases by 50%. I'm not sure I mentioned that on antepartum, but if I didn't, know that now. The blood volume will increase by 50% in the woman's body. She does not get 50% more blood vessels. So the vessels that she has will superdilate to accommodate this increased blood volume. And therefore, they get bleeding gums when they brush their teeth. It's because the capillaries are so hyperperfused. Same thing with the cervix. That's why it's blood tinged, is because there's hyperperfusion, and the little capillaries break and bleed. They also might get a little bit of weight loss, and that is not fat loss, that is fluid loss, the water shifting out of the body. That's, she's been getting edema throughout pregnancy, retaining some fluid. That'll start to go away. And so she'll lose a pound or two maybe. Energy burst, the nesting response. I have 2 kids. I don't recall ever getting nesting, so I don't know about that. But apparently it does happen, and that's just a hormonal thing, I guess. It just, they feel like they're getting ready. GI changes, nausea and vomiting might happen, and diarrhea. There's prostaglandins that are excreted with labor, and that will cause diarrhea. The prostaglandins cause contraction of the bowels and the intestinal tract, and so they'll get diarrhea. Rupture of membranes. This is a concept that may happen at any time. It can happen before labor. It can happen in labor. Well, those are the 2 times it can happen, obviously. But if it happens prior to labor, that does not necessarily mean that labor will start. Hopefully it will on its own, but if they do have ruptured membranes and labor does not start within 24 hours, then they need to be induced, because, and they won't even wait 24 hours. 24 hours, we want them delivered by 24 hours, okay? Because of this fact right here. The longer their water bag is ruptured, the greater the risk of infection. So the guideline is they should be delivered within 24 hours of that water breaking. So they will usually induce. Everybody's a little different on how they determine when to start an induction, and a lot depends on the patient's status as far as how far she's dilated and already. But they'll get them induced they'll start within about 6 hours to get them on Pitocin and get them into labor to help move towards delivery within that 24-hour period. Some women, once their water breaks, they go into spontaneous ruptured membranes. That's great. That would be ideal. Some women go into labor and their water bag doesn't break right away. It will eventually break, but to help promote labor, usually the provider will break the water bag when the patient's about 5 or 6 centimeters, because that kicks them into really good labor, unless they're already in good labor. I will tell you that when the woman's water bag is broken, the contraction intensity increases dramatically and it gets a lot more painful. Having contractions with the water bag still intact is less painful. So it's best to let them labor with that water bag intact, because it's less painful and they're still going to progress. And it also will minimize this risk of uterine infection because the water bag's not broken. Spontaneously rupture membranes is most likely to occur during transition, and I will teach you that in a slide or 2 from now when transition is. And the nurse should assess the fetal heart rate immediately after that water breaks. Why do you think that is? Okay, let's picture this out. We've got a baby with his head down here. Okay, I'm a really poor drawer. I'm not even going to try. Head's down. Okay. And we have got the mom's uterus. You should try this at home. It's safe. Okay, so we've got the placenta. We'll make this be the placenta, and then the cord going to the baby. Well, it's a long cord, longer than that. Cord. Once the water bag breaks, that baby's head's going to sit down in there, and there's a risk. Oh, can we change colors so you can see it? There's a risk when the water goes whooshing out, if it whooshes out fast, that cord can drop whoosh with the whoosh. And guess what happens? When that baby's head goes down, it sits on the cord. And it can't survive because it has literally cut off its own blood supply. So if a patient is at home and makes a phone call, my water broke, they need to get in either to the doctor's office or to the hospital as soon as possible, because we need to make sure that baby is not clumped down on the cord, cutting off his own blood supply. If they're in the hospital on the monitor and all of a sudden there's a gush of fluid and you are like, wow, her water just broke, the first thing you're going to do is check for heart tones, okay? no matter what other possible answers are on any question related to this, know that number one, once the water breaks, is to check the status of the fetus. Make sure it's still got a blood supply. So that is really important, and remember, the fetal status is always the priority. Always, 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 always the priority. Amniotic fluid performs a function other than just making the bed wet when we rupture those membranes. It permits symmetrical fetal growth, and that is exactly what it does by allowing the environment to be free enough that that baby's arms, legs, everything can grow freely. If you have a small amount of amniotic fluid, the term for that is oligohydramnios, O-L-I-G-O, hydramnios, and that can interfere with symmetrical growth. And we're going to use this baby that's on this picture here. If this uterus was, if that foot was against the uterus too much, here's the uterus, let's say a small amount of fluid there, and that foot is smushed, this baby could end up with the club feet because it sat there pushed against that uterine wall for too long, and it just developed as a club foot. Other things can happen. I'm not going to go into a list of those, but understand that if the fluid is minimal, then it's going to impinge on the ability of that fetus to grow nice and widely. Okay. Compare that to the uterus that would be nice and big. See how much bigger? See, now this baby has all the room it wants to move around, sing and dance and play, okay? So that also allows the baby to move freely and make the muscles grow. As you know, if you sat still in bed forever and didn't move, your muscles shrink. This baby also needs to have ability to move around, and so this amount of fluid, having a nice amount of fluid, allows it to kick and move and do what it wants to do and exercise its muscles and help them develop. The normal fetal lung development is enhanced with a lot of fluid because this baby, while it's in this water, is breathing. It is breathing in and out, in and out, in and out, but what is breathing in and out is fluid, not air. He's in the fluid. So the amniotic fluid, by going in and out of the lungs, is helping mature those lungs, helping them to have nice, strong musculature to them as well. Okay? Of course, we don't want the fluid in there after birth, but during pregnancy, that's what needs to happen. It also prevents adherence of the amnion to the fetus. So amnion is a part of the uterine wall. I'm not able to draw it, but if it's stuck against that, that can cause more problems with development of the fetus. It maintains a constant temperature for the baby, keeps it nice and warm at the internal body temperature, and it protects and cushions the fetus against impact. So if this mother, see, this baby is breech, okay, because here's the going out, that's the exit area, and this is the mom's head up here. So this baby is breech, and when I was pregnant with my daughter, she was breech, the little stinker. So she had her head up here, and when I was cooking, her head would bang against the kitchen counter because it was the right height. Be thump, 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 thump. And my husband was like, "You need to stop hitting her head." And I can't help it. If she'd go put her head down, she'd get it out of the way. Of course, I didn't hurt her because there's a lot of cushion between my kitchen counter and her head. There's the fluid, there's the my fat, my body fat. So it wasn't really hurting her, and that's the benefit of having all this fluid, is it prevents injury from minor things like that. Auto accidents, different story, but minor things, yeah, it helps prevent problems. This water bag also acts as a barrier to infection. We mentioned that, and it maintains homeostasis of fluids and electrolytes. So it just helps that baby has some place to pee. You know, the amniotic fluid is baby urine, fetal urine. Okay, that's where it comes from, is the fetus peeing. And we'll talk about that in another slide or two, but all of this helps maintain a normal homeostasis for that fetus in there. Clinical tests to confirm if the patient has rupture of membranes, ROM, rupture of membranes. The easiest one is pooling, and this is done by the provider. They put a speculum in and look at the vaginal fornix, and if there's a pool of water in there, then that's probably amniotic fluid. The way they diagnose that for sure would be either nitrazine tape, which is a pH strip. They would put that in that pool of water, and the nitrazine would turn from gold. It starts out as gold. It would turn to blue if it is ruptured. One thing there's several things that can affect and cause a false positive. The most common one is blood, because that area, as we mentioned, is hypervolemic and there's some blood gets in there and it can cause a false positive. But if you see pooling of water and it really looks like a little water pool and it's nitrazine positive, she's ruptured. Ferning is another really cool thing that is a way to diagnose if someone is ruptured, and this is where they take some of that pooling fluid, they take a little Q-tip swab and wipe it on a slide and let that dry. And ferning, when it dries, and then they look under the microscope, and the microscope shows a very distinct ferning pattern, and it literally looks like a Boston fern plant. Okay, it has a real, I'm not very good at drawing, but I'm gonna have fun trying. It has a real definite shape, and like I said, it looks like a fern. It's kind of cool, unless they're preterm. That's not cool, but it's cool when they're full term and ruptured to see this little ferning pattern happen on a slide. If you do get a chance that someone in the hospital is doing a ferning test, ask to see it, because it's pretty cool. Blue dye, in my whole career, I've never done that. However, you can read over here what it is. I'm not going to go over it. It's so rarely done that, I'm not even going to cover it, but you can read that on your own. If a patient's water breaks, there are some things that we would have her pay attention to if it breaks when she's at home, or of course we would have pay attention to it if it happened in the hospital and they were under our care. So prenatally, it's important to teach these women what to look for should their water break. The color is the first thing. What color was it? And since you now know that amniotic fluid consists of baby pee, it should be obvious. It should be pale to straw yellow, right? Because that's the color of urine, is pale to straw yellow. What color should it not be? It should not be green, and it should not be brown. I don't have a brown thing over here. Green and brown are signs of meconium fluid. Meconium, M-E-C-O-N-I-U-M. Meconium fluid is the result of the baby having a bowel movement in utero. Bowel movements will happen if and when when the baby's oxygen level has dropped. If the oxygen level has dropped significantly, they will poop. Okay, and this stool ends up being called meconium. So if a baby had a stool this morning, say example, and their water broke this afternoon, it's going to be brown and icky. Okay, and think of that. If you have a baby swimming in that brown icky stuff and they're breathing it in and out, you can understand that they risk for pneumonia. There's meconium aspiration syndrome, which is aspirating that meconium into their lungs, a huge bacteria in there. Those babies can get very, very sick. So it's important to note the color. We like the straw yellow. The odor, it should be odorless. Amniotic fluid does have an odor, but it's not bad. It should not smell foul, and that's the only word I can come up with. It just should not smell bad, and I can't describe it, but so the odor should be not foul. Clarity should be watery and clear. Might have little flecks of white in it, which would be the vernix that covers the baby. Is called, that's that white stuff that covers the baby that protects the skin from having problems since it's in water for so long. And that vernix might come off with that fluid, and that's normal. But it should not be bloody, okay? Bloody amniotic fluid or should not occur, because that's a sign that there's some bleeding, and it's very much a concern. The placenta is going to be the problem there. The volume of fluid should be about 500 to 1200 milliliters. It's a lot of fluid come out. And we talked about the nitrazine paper already. The mechanisms of labor, there's a video here. I hope it will load. If it doesn't load here, I'm going to ask you to hopefully to see the videos posted in your module, because that will show you the mechanisms of labor really well. When I was teaching this class on site, I had fun trying to do all these items to show the students, and it was kind of silly, but it also helped visualize. So look at be sure to watch the videos on this. Engagement is where the fetal head, remember I said it will drop down, the lightning, that's an engagement. It'll engage down in there, and it then starts to descend down the pelvis. Then the baby's head should flex as it hits the maternal cervix. As the head hits the mom's cervix and pubic bone, that head should flex downward. As I said, if it's not flexed, it is not going to deliver vaginally. So make sure, as you get experienced in labor and delivery, those of you who want to go into this field, you'll get really good at knowing what you're looking for is where are those fontanelles. Remember the fontanelles here? Whoops, let me get something a different color so you can see. The fontanelles here. And then you've got the big, that's a fontanelle there, and then the suture. I meant to say suture. And then you got your sutures. So you've got the posterior one, you've got the bigger front one, and that's how you tell if it's flexed or not, by the feeling where those fontanelles are. It needs to be flexed or it's not going to deliver. If you feel an eye or a nose, get the OR ready. She's going to have a C-section. Internal rotation is where the baby, this is the cool part, and I always like to tell dads at this point, this is going to happen when the mom's pushing, okay? She's completely dilated, she's pushing, and we're watching that baby's head come and go, come down, go up, come down, go up, come down, go up. And finally what it'll do is it'll come down, and then it'll rotate to augment delivery, and that rotation is so cool to watch. That's when dads get really excited, because the head literally turns to get out to augment the path outward. And then once the baby is out, that head will extend back, and then we deliver the shoulders, which once the shoulders are up, once the baby's head comes out, then it will restitute back to whatever position it was up here. Remember, it does that internal rotation. Then as it's what we call on the perineum, the head is out, it'll turn back to be whatever it was here. Then the shoulders get delivered and the baby goes, plop, I'm out. Look at the video on that. It's really cool to watch, and I think the video will help you understand it so much better. Engagement is when the presenting part passes the pelvic inlet at the ischial spines, and I'm going to talk about this real briefly. Your ischial spines, if you remember from anatomy, a woman's pelvis has, we got a side here, and then the spine comes out and goes down. It's very subtle, just like it is there. And I'm going to try to draw the other side. Okay, so there's an ischial spine, and here's an ischial spine. Now, if you have a baby's head coming down, up here is the baby's head. It's nowhere near the smallest. See how that's the smallest part of the mama? Okay, that head's going to move down into that, and once this head is in direct line with those ischial spines, that is what's known as zero station. Zero station. It's a testing point. If the baby cannot make it past this point, it's going to be a C-section. If the baby's head does move down to the plus part, makes it past there, then they are probably going to deliver vaginally, and these are the plus numbers. Up here are the minus numbers. Negative, above, negative. It's negative 1, 2, or 3. Negative 3 is way up in their tonsils. Not really, but plus happens down here. Plus 1 and 2, and then plus 3 is just right. They're ready to come out. Okay, so that's the station. that you want to be familiar with, and how descent occurs, and that baby's pushing down with those contractions. We talked about flexion, and this has to be the way the baby delivers, or it's not going to be delivered vaginally. It'll get delivered, just not vaginally. These are the other, I just kind of went through these, that internal rotation and extension, external and expulsion. So look at the video on that. That's going to make it a lot more clear. These are the stages of labor, and I do want you to be familiar with these. It's important to understand what the stages are. The first stage is from the onset of labor until completely dilated, which is 10 centimeters. That's how far they have to get dilated, 10 centimeters. And that stage, the first stage, is made up of 3 phases. Okay, the first phase is called latent. This is the phase where they're giggling and they're excited and they're on Facebook, or they might be walking the mall. They're all excited. They're playing on YouTube or on, Facebook or Pinterest or whatever. They're just all excited. I'm in labor. I'm gonna have my baby today. La, 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 la. And we know by looking at them, they're in latent phase. Cervically, they're either 0 up to 3 centimeters. That's that early phase, up to 3 centimeters. Usually pretty cool, easy to get through. Then around 4 centimeters, things generally get a little more intense. Things speed up. This latent phase, before I move on, past it, latent phase is the longest phase of labor. This 0 to 3 can last hours. Many hours, okay? Once they get into the active phase, that's exactly what it means. It gets more active. They go from 4 to 7 centimeters, and it happens much quicker than this latent phase. It happens within a few hours, very few hours, and this is when they're going to start begging for medicine, epidural, medication, something. This is when they start feeling really scared because I don't think I can do this. I don't think I can do this. And it's up to us as nurses and midwives and providers to reassure them that your body is made to do this. You're going to do fine. I'm here to support you. And of course, if they want an epidural, this is when they would get it. Transition, this is another, this is a whole other animal. This one is from 8 to 10. The cervix gets completely dilated. This is when they, if they're going to hate their husband, this is the phase where they hate their husband. If they're going to be really irritable and angry, this is when it's going to be. This is when they're wanting to stop and go home. This is when they, and this goes very fast. This might last 2 minutes to an hour. Okay, this goes really, really fast. And this is the exorcism phase. Their head goes around 360 degrees and they are mad. Now, if they have an epidural, they won't be, but we're talking the non-medicated patient. Lots of rectal pressure. They want to push, and we don't want them to push until that cervix is completely dilated, because if they push and there's still cervix there, they're going to swell that cervix up, or the cervix can tear. And if it cervix tears, it has to be repaired after delivery. So we want to prevent that. So we help them by blowing, pant blow, pant blow, pant blow. Do not push, do not push. Help them, okay? So now we've gotten them completely dilated, and we're on to the second stage. That's where we're going to deliver the baby. This is the pushing stage, from 10 centimeters up to birth. Yay, baby's out. And that can take up to 2 hours for a first-time mom, even 3, but about 2 hours first-time mom. Second-time mom should be faster. And I'll talk about these first-time, second-time in a second. Let me finish this chart. So we push the baby out. That's second stage. Third stage is when from delivery to the delivery of the infant to delivery of the placenta. That's very quick, should be within 5 or 10 minutes, up to 30 minutes sometimes, should not go much beyond that. Fourth stage is from the delivery of the placenta till the mom stabilizes her vital signs, and that can just take a few hours. And we also call the postpartum time part of the fourth stage, okay? I think there's a fifth stage personally, because when I delivered, and I didn't feel like me, I didn't feel like Diane again until I was like a year later. I was okay, I was back to work and all that, but oh my God, finally after about a year I went, you know what? I think Diane is back. It was very strange, very obvious. So I believe there's a fifth stage personally. Okay, let's talk about the primigravida, multigravida real briefly. The primip is someone having their first baby. they are going to have the longer labor because it's not ever happened to their body before, and their muscles haven't stretched, their cervix hasn't opened before. So that takes about 8 to 10 hours for that complete dilatation. Can even take longer. I think 18 hours is actually the average length of first-time labors. Multigravida, they will dilate much faster, and there's it says 2 to 10 hours. The rule of thumb is for a multigravida, if they had a 10-hour labor with their first baby, their second baby will probably be about a 5-hour, about half the time. It's pretty much a general rule. Third babies are a different story. I'm not going to talk about them, but they're little stinkers. I will tell you real briefly, the third baby, the mom will dilate to 6 and be 6, 6, 6, like forever. She's contracting and she's 6, 6, 6, and she thinks this is never going to happen. The truth is that baby will deliver within 2 contractions. We just don't know which 2 contractions they will be. And that's truly it. There's 6 and then they'll go complete delivery. 6, 6, 6, complete delivery. So it can be frustrating for them. So if they know that's a typical pattern, they are less frustrated. So just get familiar with this chart, understand the maternal needs during the different phases and stages, and what you as a nurse should be looking for. These are the videos I'd like you to look at. I'm not sure you'll be able to see them here, play them from here. So look at the posted PowerPoint that's not recorded, and watch these deliveries. These 3 here are cute. Okay, these are just cute ones, and you'll enjoy them for their cuteness. And then these are learning ones that are going to show you that mechanisms of labor in the station and exactly what I was telling you to watch for. And then a C-section will be shown. This final slide I've included so that men feel very much involved as part of this whole thing. And so I'm going to read this to you so you know what this is. Among the Hokal Indians, the father traditionally, here's dad, sits above his laboring wife in the rafters of the hut with a rope tied around his testicles. And when his partner felt a painful contraction, she would grab the rope and tug so that he too would experience the pain, which would bring new life. So that is how dads got involved. Okay, yeah, I'm not promoting this. It's just kind of fascinating how much those people wanted their husbands way more involved than our current day people. Anyway, I hope you enjoyed that, and thanks. Hope this helps you understand labor and delivery a bit.